These are the learning objectives for enhanced recovery after surgery. Discuss the goals of ERAS pathway. Discuss the preoperative and postoperative components of ERAS. Describe the benefits of the ERAS pathway. Discuss anesthetic medications and perioperative components of ERAS. And describe common barriers to the implementation of ERAS. In the early 1990s, Danish professor Henrik Kalet first envisioned enhanced recovery, or fast-track protocols, with the goal of providing patients with safe and painless surgeries and shorter hospital stays. In stark contrast to many deep-rooted traditional surgical tenets, this new approach to patient care management was very slow to gain acceptance. 2 decades later, enhanced recovery after surgery strategies are finally catching the wave of popularity in the United States, in particular for those patients undergoing major abdominal, thoracic, and urological surgeries. These guidelines, published by the recently formed Enhanced Recovery After Surgery Society, provide care teams with comprehensive and evidence-based approaches for the perioperative management of surgical patients. Considering that every aspect was born from existing evidence gathered from the perioperative medicine literature, ERAS guidelines simply integrate these concepts into a unified pathway approach to clinical patient care. Given that standardization of medical care has been associated with improved outcomes and lower healthcare costs, these protocols were designed to reduce psychologic and physiologic stress with the final goal of lessening complication rates, enhancing functional recovery, and reducing the length of stay. Let's look at a couple important definitions and distinctions. ERAS, or Enhanced Recovery After Surgery, is defined as a concept of multimodal postoperative recovery pathways to minimize the stress on the body to directly minimize the time needed to recover. Fast Track is a concept of using treatment algorithms for the protocolized care of specific and similar groups of patients to move them through more effectively and more efficiently through the process of disease management. Minimally invasive surgery, in the context of ERAS, generally signifies laparoscopic surgery utilizing small incisions, cameras, and special instruments. However, this can also include robotic surgery. Multimodal analgesia. This is the utilization of 2 or more analgesic medications using different mechanisms of action. Frequently used with the goal to limit opioid use. This frequently includes acetaminophen and non-steroidal anti-inflammatory drugs. This also refers to using regional techniques such as neuraxial anesthesia or tap blocks. Patient-controlled analgesia, or a PCA. Patient-centered administration of pain control. This is typically used to describe IV opioids. It can also be applied to epidurals when a patient pushes a button to release medication on demand in addition to a potential basal rate. We will start with some background with the latest data release, although it is still several years old. The Agency for Healthcare Research and Quality estimated that direct medical costs for all aspects of cancer care in the United States in 2011 approached $90 billion. 35% of this amount reflects inpatient hospital encounters, including surgical procedures. The American Cancer Society expects over 1.5 million new cancer diagnoses, excluding carcinoma in situ and basal cell or squamous cell skin cancers. Nearly 300,000 of these cancers will be of the digestive tract. Surgery is the most common treatment for colorectal cancer, with a variable cost from several tens of thousands of dollars up to several hundred thousands of dollars, according to CMS. This wide variability of cost reflects, in part, the impact of perioperative complications requiring higher levels of care and longer hospital stays. Based on published 2008 trend predictions, its 2020 costs for colorectal cancer treatment in its initial, continuing, and final stages is predicted to total $5.19 billion, $3.57 billion, and $5.27 billion respectively, for a total cost approaching $15 billion. ERAS represents a paradigm shift in perioperative care in 2 ways. First, it re-examines traditional practices, replacing them with evidence-based best practices when necessary. Second, it is comprehensive in its scope, covering all areas of the patient's journey through the surgical process. Not only do these protocols force the re-examination of traditional perioperative practices with early feeding, early mobilization, and early goal-directed physical activities, they are also comprehensive in scope, covering all areas of the journey. Fast-track protocols with multidisciplinary teams are a paradigm shift in the customary approach to the surgical care of patients, and as such, EROS has been a challenge to implement universally. In this lesson, we will focus on the components of EROS that are common to every guideline. In addition, because the colorectal pathway has been the most validated, we will also present components unique to those guidelines. The Enhanced Recovery After Surgery Society provides comprehensive and evidence-based guidelines for perioperative management for multiple surgical procedures. The key factors that keep patients in the hospital after surgery include pain control requiring parenteral analgesia, slow return of bowel function necessitating intravenous fluids, and impaired mobility requiring bed rest. The central elements of the EROS pathway address these key factors, recognizing that each aspect interacts with the other to affect overall patient recovery. Additionally, EROS pathways provide direction to all perioperative care partners, guiding everyone to work as a well-coordinated team to provide the best patient care. The goals of EROS are to establish standardized guidelines for perioperative care interventions to improve patient outcomes. Using a multidisciplinary approach, EROS is focused on decreasing hospital length of stay, reducing complication rates, and improving the return of functionality with subsequent reduction in overall healthcare costs. This is accomplished by following anesthesia and analgesia plans even for minimally invasive techniques, the use of goal-directed fluid therapy to avoid bowel edema, early nutrition with the prevention of nausea and ileus, and considering thromboembolic prophylaxis to be early mobilization. As EROS pathways have been utilized extensively in Europe, studies have shown that adherence to them can reduce care time by more than 30% and reduce postoperative complications by up to 50%. While each of the current EROS protocols for the different types of surgery have certain variations, they are all derived from evidence-based practices. Each protocol shares a multidisciplinary approach aiming to optimize conditions before, during, and after surgery to reduce the length of hospital stay for patients after surgery. During the preoperative phase, attention is focused on preparation of the patient both in the weeks leading to the surgery as well as on the day of surgery prior to entering the operating room. This helps to alleviate psychological stress and optimize comorbidities. Patients should routinely receive dedicated preoperative counseling and education, not only focusing on the surgical aspects of their care, including the potential need for an ostomy, but should also include a thorough discussion regarding expectations and goals for discharge. While the evidence level is specifically low for this component, EROS strongly recommends this as it improves patient satisfaction. Preoperative optimization of comorbidities and organ function is important to ensure the safest and smoothest course possible. This includes smoking and alcohol cessation, ideally 4 if not 8 weeks prior to surgery. Maintaining ideal glucose and blood pressure control prior to major surgery is also paramount, as well as ensuring proper nutrition to avoid tissue catabolism. Patients are also kept warm during all phases of care, including the time they are in the hospital awaiting their surgery. Additionally, oral mechanical bowel preparation is not recommended since it has not been shown to have any proven benefit. These guidelines use a multidisciplinary approach to optimize patient outcomes by targeting interventions during the pre, intra, and post-operative phases. On the day of surgery, specific preoperative interventions include the avoidance of prolonged starvation time, as well as providing carbohydrate loading. As such, EROS protocols encourage clear fluids for all patients up to 2 hours prior to surgery, advocating for a shorter 6-hour interval between last solid intake and surgery, and recommending oral carbohydrate loading in the preoperative holding area for those not prone to hyperglycemia. During the intraoperative phase, EROS is focused on both specific intraoperative management as well as optimization of pain and fluid management in preparation for postoperative recovery. Routine recommendations such as antimicrobial and antithrombotic medications are included in the EROS guidelines. The initial dose of antimicrobial prophylaxis should occur before incision and may need to be redosed. There is a specific focus in EROS on antithrombotic prophylaxis. Heparin or low molecular weight heparin are recommended 2 to 12 hours before surgery and should be continued until patient mobilization and potentially for an additional 4 weeks. Importantly, because of the recommendation of routine epidural use for open abdominal surgery, which will be discussed later, the timing of antithrombotic prophylaxis is crucial to limit the risk of epidural hematoma. The American Society of Regional Anesthesia has produced guidelines regarding the timing of anticoagulation medications and neuraxial anesthesia, which are beyond the scope of this lecture. Routine use of epidural anesthesia is one of the key components of EROS. It has been shown to be superior to patient-controlled analgesia in relieving pain when the catheter is properly positioned. In addition, it is also associated with decreased stress response, improvement in pulmonary function, decreased risk of postoperative pneumonia, and reduced insulin resistance. However, evidence is conflicting regarding whether epidural analgesia increases or diminishes the length of stay. To ensure the efficacy of epidurals, they should be tested prior to the induction of general anesthesia, since a significant percentage do not function adequately. They should be activated before surgery and continued for 48 hours while transitioning to oral multimodal analgesia. While epidurals are recommended for laparoscopic surgeries, they have not been proven superior to spinals or PCA. Epidural administration of local anesthetic leads to a lower rate of ileus in laparoscopic procedures. Specifically, in laparoscopic colorectal resections undergoing the EROS program, there was no difference in return of GI function and length of hospital stay between thoracic epidural and a continuous IV lidocaine infusion. In general, intravenous lidocaine is known for its analgesics, anti-inflammatory, and anti-hyperalgesic properties and is moderately recommended in the EROS pathway. EROS provides a few recommendations with regards to intraoperative anesthetic management. These include using short-acting medications such as induction agents, opioids, and muscle relaxants, and titrating anesthetic needs to the bispectral index, especially in the elderly population to avoid oversedation. A strong recommendation is for low tidal volume ventilation to decrease barotrauma and volutrauma and their associated postoperative morbidities. Given the importance of decreasing the length of stay as a goal of the EROS pathway, and that up to 70% of patients undergoing major abdominal surgery have postoperative nausea and vomiting, which can delay discharge, the prevention of PONV is naturally an important focus of EROS. PONV should be treated using a multimodal approach both prophylactically and if present after surgery. Risk stratification using a PONV scoring system can aid in a tailored approach. Antiemetics may be cholinergic, dopaminergic, serotonergic, histaminergic, or a neurokinin-1 receptor antagonist. Avoiding inhaled anesthetics, utilizing regional anesthetic techniques to minimize the need for opioids, and prophylactically treating with antiemetics are part of this multimodal approach. If PONV is present despite prior prophylaxis, consider choosing an agent from another therapeutic class. While dexamethasone has antiemetic effects, its immunosuppressive effects on oncology patients is still unknown. Additional measures to enhance outcomes include temperature management, fluid management, and glycemic control. Avoiding intraoperative hypothermia leads to decreased rates of wound infections, cardiac complications, bleeding and transfusion requirements, and post-anesthetic recovery times. Cutaneous warming systems such as forced air or circulating water garment systems are highly recommended. Strict attention to fluid balance and avoiding sodium overload has also been shown to improve outcomes. This can be attained by providing balanced crystalloid, preferred over normal saline, solutions, and high-risk patients may benefit from Doppler-guided fluid management. Care should be taken to avoid interpreting epidural-induced hypotension as hypovolemia. Vasopressors may be more appropriate in this setting. Ideally, by adhering to the other components of EROS, postoperative glycemic control can be optimized by decreasing insulin resistance that can occur after major surgery, even in patients without diabetes. As mentioned, these measures include avoiding preoperative fasting and oral bowel preparations, using oral carbohydrate treatment, reducing the stress response with epidural anesthesia, and optimizing fluids and avoiding systemic opioids to affect the early return of gut function. Other intraoperative interventions include thromboprophylaxis, antibiotic prophylaxis, normothermia, avoiding nasogastric tubes and surgical drains, fluid optimization, and minimally invasive surgical approaches when appropriate. Focusing on preoperative and intraoperative management aims to ensure a smooth postoperative course. Accordingly, there are few specific postoperative recommendations. By using a multimodal approach for PO&V and adhering to excellent fluid balance, ileus should be a minor problem postoperatively. However, EROS strongly recommends avoiding nasogastric decompression, while laxatives and chewing gum are weakly recommended to accelerate gastrointestinal transit. Urinary drainage after surgery should be accomplished with transurethral catheters, which can be removed safely on post-op day 1, even with a thoracic epidural in place. This leads to lower infection rates without an increased rate of recatheterization. If urinary drainage is required for more than 4 days, suprapubic catheterization is probably superior. Early and scheduled mobilization is strongly recommended, even though the evidence level for this is very low. This should occur on the morning of post-op day 1 with detailed daily postoperative targets. Ensuring adequate analgesia using epidurals and optimal pain management permits movement. Coordination with physical therapists and occupational therapists is crucial to ensure safe and early mobilization. Postoperative interventions include gut mobilization, opioid-sparing analgesia, multimodal antiemetic regimens, early removal of urinary catheters, and early mobilization. Let's take a look at one of the most common group of surgeries for which EROS is utilized. In addition to common recommendations for all surgeries covered by the EROS protocols, there are some interventions that are specific to colorectal surgery, which still accounts for the majority of surgeries that currently follow the EROS guidelines. Laparoscopy is highly recommended over open surgery since it is associated with shorter length of stay and lower morbidity. Perhaps laparoscopy can be considered to be the key intervention in the EROS pathway since many studies point to laparoscopy alone as a cause of a shorter length of stay. However, when compared to laparoscopy and conventional therapy, EROS with laparoscopy was still associated with shorter lengths of stay. In general, tubes and drains are avoided in EROS. Specifically, NG tubes should not be used routinely. In addition, drainage of the peritoneal cavity after colonic anastomosis should be avoided, as there is no proven benefit and it can impair early mobilization. Postoperative analgesia is extremely important and needs to provide adequate analgesia, allowing for early mobilization while minimizing complications such as delayed return of gut function and feeding. Within all the EROS guidelines, avoidance of systemic opioids is strongly recommended for improved outcomes. Techniques utilized to decrease requirements of systemic opioids include regional techniques such as epidurals, spinals, and tap blocks, intravenous infusions of lidocaine, and utilization of NSAIDs. Specifically for laparoscopic surgery, mid-thoracic epidurals were found to be associated with earlier return of GI function and tolerance of an oral diet when compared with systemic opioids. There is ongoing investigation about the use of spinal anesthesia and tap techniques for laparoscopic surgery. Because EROS is a relatively new concept, there is limited evidence regarding its efficacy. What evidence exists is focused primarily on elective colorectal surgeries. The existing evidence points to overall improved patient care, especially in decreasing the length of stay without an increase in complication or readmission rates. The most recent meta-analysis by Zwing and others of 1,910 participants concluded that ERAS was associated with decreased lengths of stay by 2.5 days and decreased total complications with a relative risk of 0.71. Another meta-analysis by Lev et al. Showed similar results with decreased lengths of stay by 1.9 days and an overall decreased rate of complications. In 2011, a Cochrane review assessed the effectiveness and safety of the ERAS multimodal strategy compared to conventional care surgery. It also found that length of stay was significantly reduced by almost 3 days, with decreased complication rates with no difference in readmission rates. Implementation may be difficult, as it requires involvement by surgeons, anesthetists, nurses, physical therapists, nutritionists, social workers, and a potentially dramatic shift in clinical workflow. While some critics argue that part of the benefit of the ERAS pathway can be attributed to patient selection with relatively healthier patients and a younger population, there have been several studies that have shown that ERAS is also safe in an older patient population. Furthermore, the average age in most ERAS trials has been over 60. Postoperative recovery is confounded by pre- and intraoperative measures. Therefore, it is difficult to measure the unique benefits of the postoperative components of ERAS. Previous data has shown that early mobilization and the initiation of oral diet are associated with shortened lengths of stay. However, they could be signals of improvement of recovery after surgery due to the pre- and intraoperative factors. ERAS programs are not widely accepted in the United States. This may be due to the fact that most of the initial studies and institutions involved were in Europe. A multidisciplinary approach to the fast-track surgery requires a multidisciplinary team. In addition to the surgeon, anesthesia provider, and nurses, physical therapists, intraosseous therapists, nutritionists, and social workers are all part of the team and should be trained in the fast-track surgery principles. Making changes within so many different units and shifting existing clinical routines requires significant dedication from all involved parties. Further support personnel may be required to collect and maintain data. Within the ERAS guidelines, there are approximately 20 listed puzzle pieces. This can be overwhelming to launch. In addition, the relative contribution of each intervention remains uncertain. As such, there may only be modest enthusiasm by a particular institution. There is also a lack of general knowledge about the efficacy of ERAS and its improved outcomes. As always, there is a delay between dissemination of information and implementation of evidence-based medicine. In conclusion, ERAS protocols were initially described and validated for open colorectal surgeries, but have since been studied in a variety of other surgical specialties, including thoracic and urologic surgeries. Although growing evidence from several randomized controlled studies, systematic reviews, and meta-analysis suggests substantial benefits with adherence to ERAS protocols. Although growing evidence from several randomized controlled trials, systematic reviews, and meta-analysis suggests substantial benefits with adherence to ERAS pathways, there is still colossal struggles when introducing these evidence-based guidelines into routine daily practice. Namely, a multidisciplinary team is required, with all team members being familiar with ERAS philosophies and being motivated to carry out the protocols. To do so, all must overcome traditional concepts, teachings, and attitudes toward perioperative care. In light of such compelling evidence, the evidence-based environments in which we practice demands a review of this perioperative approach to patients requiring major surgeries so that we may alter our practice accordingly.